Is on. Okay, Victor, do you want to kick off for us?
Yeah, absolutely. So, good night. We're here again with the Miami, Coventry, London connection. I'm actually leaving to Spain tomorrow, and Jamison is going to be in Spain on the 18th as well. He's gone to the factory. Sergio is right now in Dubai. Okay, so we're getting as glamorously international as you can possibly get for the time being. Today is going to be a day where I am going to have less participation, mostly because it's going to be a lot of clinical background explaining how to resolve certain conditions for patients, showing a beautiful medical software that Abid has, and also how can we apply those steps into a prescription. With Edser, we have some samples done just for the occasion, and I'm going to give the word to Abid so we can start speaking about the first subject, which is Morton's neuroma.
Brilliant. Okay, so today we're going to go through the top five prescriptions that we've come up with, 5 of the most common prescriptions for common conditions. We're going to go through some of the basic anatomy and physiology behind those conditions, but just a very brief overview, and then we're going to get straight into the nitty-gritty and the most important stuff, which is what type of prescription and how to fill in a prescription for this. So I think we've agreed already. We're going to kick off with Morton's neuroma. I'm playing with the software in the background because it's crashing on me, but I'll get back to you as soon as it starts working. It's just really slow to load up, so bear with me on that one. In the meantime, let's talk about Morton's neuroma a little bit. So this is a very painful condition affecting the ball of the foot, the forefoot. Essentially, I call it, in layman's terms, I call it a trapped nerve in your foot. This affects the plantar digital nerves. Some will say it's a neuroma or fibroma on the nerve ending as it passes through the intermetatarsal web space in the ball of the foot. This can give a burning, shooting, nasty pain right in and around the base of the toes in the metatarsal area, also commonly known as metatarsalgia. These nerves can become very swollen, very inflamed, very irritated, and can often end up, if not properly managed conservatively, ending up requiring surgery and a surgical intervention to remove the painful nerve from the foot, which is a debilitating surgery, and the long-term recovery is difficult, and also there's a good chance of recurrence of symptoms. So where possible, we want to manage this conservatively, hence why orthotics are key and extremely useful. If you catch that patient at the right point in time, you can help to prevent them going on further to have invasive injections and surgical procedures. So kicking off with Morton's neuroma, we're going to talk about a basic prescription. So of course, the thing about Morton's neuroma is within the prescription, we're trying to control and stabilize the rear foot, the midfoot, and the forefoot, and also we're trying to give some metatarsal pressure from underneath the metatarsals, the long bones in the forefoot, to try to open up the web spaces there to allow space for the neuroma to exist and to prevent compression of the bones on the interdigital nerves. So this is why orthotics are very, very important. Often we'll find patients have poor biomechanics of the foot. They tend to lose a lot of the intrinsic musculature. Generally speaking, from what I see in clinic, they tend to get a kind of retraction or hammering of the toes and a dropping of what we in old money called the transverse metatarsal arch. And that's exactly what we're trying to restore with a good orthotic prescription. So I have a sample here. Hope you can see this on the camera. So here is Edser's sort of prefabricated version of a prescription for a Morton's neuroma. So initially you can see we have a real thin shell. This is in actual fact a 3D print shell. So you can see a lot of ease of fitting into footwear because that actual shell is contoured and molded to help to restore the architecture or reduce overpronation. And at the same time, if you look here on the top, we have this either a metatarsal bar or a Morton's pad placed on the top, or sometimes a bit of both. So there's this kind of basic standard version. and people often will alter their prescription depending on the individual needs or the type of footwear they've got to get. But initially, you can see how super cool and super sleek this device is, and so it's really easy to get, particularly into ladies' footwear, where we probably see more ladies with this condition than gentlemen. So for discussion for you guys, I'd do things a little bit differently, perhaps, depending on the individual. But if you want to kick off, how commonly you see this prescription going out from the lab? Is this an absolute standard, or do you see many variations of this theme?
We actually see quite a bit of clinicians who use a metatarsal pad even as a standard in most of their devices, and then we'll shift away from it for certain other specific conditions. And we also, of course, see, as you said, many women particularly, but both men and women with Morton's neuroma or metatarsalgia, who the clinicians will use a metatarsal pad for.
So this is the standard. Is this type of shell, the 3D print? Is that the most common feature that you see coming through, or do you have variations of the different types of materials? Because you guys offer quite a wide range. But what's the most common feature you find? I mean, because we're trying to make life as easy as possible for people thinking about prescribing. So how commonly is it to 3D print compared with a polypropylene or carbon fiber or some other kind of material?
I would say the 3D print is the most common at this point, particularly, as you said, for women or men who are wearing shoes that don't have quite as much space to accommodate an EVA type insole. Sometimes, and more in the past, they're using the graphite and carbon fibers as well. However, now that we have the different features with 3D printing instead of just polypropylene, they find that they can keep the shell just as thin as they needed it to be, as supportive as they need it to be, but a bit more flexible than the carbon fiber and graphite, so it's more comfortable on the patient's foot.
Yeah, it's pretty good control in this. You can't quite see all the contours in there, but it's actually quite a good stuff. It is semi-firm, applying quite a bit of pressure here, and you can see that it's not really flexing too much. So an EVA, of course, would be much more flexible, more than likely. And a polypropylene or carbon fiber type of plate would be much stiffer, much more rigid, and less able to tolerate. So this is a real nice. If you can see, I'm giving some pressure to the arch, so it will flex and enable comfort of the device. Do you often see posting on the rear foot, antipronatory sort of valgus wedges being put in there, or do you just tend to see that you find that the actual 3D print can capture the neutral position of the foot well enough that we can keep it in that plane without having to add multiple wedges? Because of course that adds bulk to the device and makes it even more difficult to fit in the footwear.
Yeah, it depends, of course, on the patient and their condition and alignment. We believe our philosophy is that we can do the majority of the correction in the majority of the cases with a good custom arch support. However, there's certainly reasons and conditions that we might get into with some of the other conditions later, where you might have to or want to use a posting instead of a full contact arch, because you're concerned about the forces and pressure in specific areas, specific anatomy that may be sensitive, inflamed at the time. We can, however, do the postings intrinsically as well, which is one recommendation that I give to the clients. Because once you do get it inside of the shoe, it's going to be stabilized by most footwear. So you can do the intrinsic posting and it's not going to rock as much as many people might think it would.
Intrinsically and flat heel.
Yeah.
Always.
Exactly.
I just want to show the audience the tri post that you get on the EVA devices, because of course this is quite unique stuff. There's not many labs around doing these 3D print with the tri posting. So if you need to put valgus or varus control or posting in there, you can see how nicely that can be blended in to the actual 3D print in the device, and therefore you don't need external wedges gluing on in place. It can be really nicely built in there if you need to stabilize the heel, or if you need to. I think this is showing a varus wedge on there, so you can see how nicely that'll sit in. And still, if you do add posting, you're not going to sacrifice too much depth in the footwear.
Yep.
With the cool 3D print option. Great.
Abid,
So
you want me to take them through filling out the order form for this one, at least just to show the process, and then
yeah, that'd be great. I think we clarify that this is kind of a standard in the industry. The way we treat Morton's neuroma. So there's no rocket science behind it. It's just about getting the device to fit and work best for your patient. So yeah, talk us through it, please, Jamison. That'd be great.
Yeah, I'll just take you guys through. Actually, I think we should show my screen. I guess we don't have yours up, so I can do it right away.
Yeah.
So to start prescribing your order, you're just going to open up the windows by hitting edit. You'll choose your product type, which in this case is going to be an orthotic. And when I do it, I typically just go across like any document, left to right, top to bottom. So your shell materials, as mentioned, we have a larger variety of shell materials, but we're focusing on the 3D print right now. So there's EVAs, polypropylenes, your carbon fibers. In this case, the order that Abid showed you on the screen was a 3D printed 2 millimeter shell.
Yep.
When you're trying to keep it thin, I'll usually keep it at 2.5 millimeters, 2 if we need it even a little bit thinner. And then based on the patient weight, obviously you might have to go up, and we can do some modifications later that would allow you to accommodate for that in different ways. The orthotic style, as we've discussed previously, our main three are versatility, which is your normal grind or width, performance, which is a bit extra wide, and moto, which is more narrow for a dress insole. In this case, I believe Abid showed you a moto, which is a dress. The top cover he has selected is a black leatherette. We also have a variety of EVAs, neoprene, plastizote, EVA latex, different fabrics, a large variety of options for you. For the bottom cover, our standard is black 1 millimeter EVA. It matches all the colors. It's durable. And it has some grip at the bottom of the shoe. Extra cushion, we're not going to add any right now, but you could add 3 different thicknesses of cushion for patient comfort. And then the length, in this case, we had sulcus, which is going to be a 3/4 length coming underneath the metatarsal heads, but not through the toes. And our heel cup, in this case, we're trying to keep low profile, is 5 millimeters. Arch contact, as discussed earlier, you can do a full contact device, or depending on the patient's weight, the patient's activity level, the materials that you use, you can modify that either -3 millimeters or -6 millimeters. We'll keep it full contact for now. So you'll just save that. Then we'll get to the components or modifications and accommodations for the order, which are the additions and subtractions that are patient specific beyond the custom arch support. Your wedges, we're going to skip past because those would be used for EVA devices, at least in the rear foot. Your postings is what you would use in a 3D device typically. So as Victor mentioned, we like to use a flat heel and no posting generally. If you were going to use a posting in this type of device while we're trying to keep it low profile, you could add 3 millimeters, 5 millimeters, whatever it is, varus or valgus, and then you would select intrinsic so that it's not additional material on the outside of the device. So we'll stick with no posting for now. For this particular patient's diagnosis, we discussed that it's going to be a metatarsal dome pad. This padding would usually be specific to Morton's neuroma or pain in and or between the 2nd, 3rd, and 4th metatarsal heads. A standard for low and non-aggressive would be 3, or high would be 5. I would usually stick with soft or semi-soft material. In the case that the patient has more widespread metatarsal pain, neuroma between other digits, or you're just looking for a more generalized treatment, a met bar is certainly an option as well over here. And in the case that you have a specific neuroma in say space 4-5 or 2-3, you could, or 1-2, you could also just use a Neuroma pad, which is a smaller interdigital pad that would go just into those spaces. So you really have multiple options for trying to get the best treatment. When you finish, you'll just kind of want to make sure everything is saved and go up and down and review. I'm actually realizing now that I've skipped something. So you can open back up. And as you may have seen on the bottom of the orthotic, when Abid flipped it over, we can increase the arch reinforcement in two different ways, either with medial arch reinforcement or triple arch reinforcement. You can see the difference in the pictures.
Yeah, you have the medial arch reinforcement.
Yep. So we're going to add that in. So that way we can keep the shell nice and thick and a bit more accommodative and comfortable as it contacts the patient's skin around the weight-bearing surface of the orthotic, while giving the extra support needed in the medial arch so that you don't get collapsed and it's nice and strong, as Abid showed. So there you are again, and you have your complete order.
Brilliant. Cool. Nice and clear. But yeah, hopefully that gives everyone a basic overview of Morton's neuroma, indications, and types of prescriptions. So we can go into this in a lot more detail in future programs. But for the orthotic bit, let's skip along then, guys. If there's nothing else to be said on the Morton's neuroma bit, should we head on to
yeah, Abid, use the samples that you have just to show them, and you speak about it, and then I will just show in the order form the specific modifications that are added for that diagnosis.
Perfect. Okay.
Yep.
So next up is heel spur plantar fasciitis. So hopefully you've got your prescription form ready there. I'll pull out the prescription. So this is again Edser's 3D print for heel pain plantar fasciitis. So heel pain plantar fasciitis, as it suggests, pain generally speaking on the bottom, the sole of the heel. It generally affects the ball of the heel, and this can cause a great deal of pain and inflammation, generally characterized by first thing in the morning pain. That first step, getting out of bed in the morning, can be incredibly painful, making it difficult for the person to bear weight on the heel. It generally goes throughout the day, with the patient being able to put weight through the heel due to the pain, swelling, and inflammation. And it can be a chronic long-term condition that can affect somebody for anything from 6 months to 12 months. So, of course, during this time, the biomechanics of the individual is affected to such an extent that they can often end up developing knee problems, shin problems, hip and back pain. So we want to try and get this sorted as soon as possible, because if we don't, again, this can end up requiring further medical intervention, for example, injections or even surgery. So we want to do whatever we can to help that conservatively, and orthotics, particularly in my practice and generally across the globe, is one of the first things we want to do for our patients presented with such a condition. So let's talk about the device itself. So for plantar fasciitis, a couple of key features really. One is you want to correct the underlying biomechanics. So your thorough assessment of the patient will help you to decide on the appropriate prescription for it. But we're looking right here at a general sort of, this is a preset model that Edser have built in to the prescription. So you can use this preset model because it's got most of the features that you require, and you may want to just add in a little addition yourself, maybe a little bit of varus or valgus wedging or any number of additions that Edser offer on their fantastic app. So let's have a look at the device. So this is an example of, again, immediately you can see the actual thinness of the 3D shell itself. Then on the top, we have a nice thick, I think this is a neoprene cover.
Yes.
The benefit of that, of course, is it's incredibly cushiony, and it gives a lot of pressure deflection qualities. So one feature is the fantastic arch. So if we have a look, this is a real thin shell. It's I think it's a 2 or 3 mil shell maybe. So if you look, I'm putting some serious pressure through this, and you do have some flex, but it's not going to lose its continuity totally. So that will help to deal with any overpronation. You have a slight heel cup to this, and then within the actual heel itself, I think you can just about make that out on the picture. You can see a heel spur pad fitted in right here. So that is a general recommendation from Edser as to where you should start with your plantar fasciitis prescription. And I generally find that there's no point reinventing the wheel on a lot of these prescriptions. You know, this is tried and tested methods. There's a lot of research, a lot of evidence behind orthotic prescription, basic orthotic prescriptions, and it's just for you to be able to tweak that maybe to make it work the way you want it for your individual client or patient. So Jamison, anything you want to say about the basic choice of materials here on this type of device? Why did Edser go for 3D print again as opposed to polypropylene or even an EVA device, and why the choice of the neoprene top cover?
In terms of 3D print versus EVA, EVA can be very good for this diagnosis and patient presentation as well. 3D is just quite versatile, as we keep harping on, because of the different features that it allows us to print into the shell. Typically with your plantar fasciitis patients, it depends on footwear, of course, but they have been having, as with most patients, but some discomfort in the bottom of their feet. So by giving them that extra padding, as well as still being a durable cover, and not too grippy, it just feels comfortable on the bottom of their foot, which helps with an initial sensation, not only in the direct area of pain, but throughout the foot. Let me go back real quick to the prescription form. All right, so just a few of the features that Abid just showed. We're going to have the arch density reduction built into this one, and that's going to allow us, especially in the presentation of many cases with a more rigid cavus foot, it's going to allow us to have a true full contact arch while softening up that sweet spot in the arch, which may be inflamed and painful to the touch for these types of patients. And the other possibilities, it really depends a little bit. You can play with it depending on the exact presentation. The plantar fasciitis as a blanket term, really the patient can have more of a heel spur or insertional pain, where you see this dot right here on the screen. That can be where their area of pain is. They could also have it through the midfoot, again, where this arch density reduction is, or they could have it right behind the metatarsal heads where the insertion is. So if you have it, as I just mentioned, where the patient has point tenderness to the center of the heel, and or specifically a calcification in the heel, you can select a heel hole that's going to actually open up the shell, and you can fill that with Poron, with nothing, or with very soft material. And then you can also add, that was on the device Abid showed, a horseshoe pad, which is going to create a little bit of a ring on the exterior of the heel cup that's going to elevate the center of the heel so that it's not pushing down into the middle of the shell. On the other hand, if it's not really the heel pain as much as in the arch and distal, more towards the metatarsal heads, you might want to get rid of that for the patient if it's not necessary. And again, you might want to add something like a Met bar, because now you're supporting the transverse arch and preventing the total arch collapse, so that the origin and insertion aren't being separated from each other with every step, pulling on the insertion in the mid-belly of the fascia. So I would say those are the properties that you would most want to change on the plantar fasciitis device.
There it is. So we were looking at the plantar aspect of the heel here. You can just about make it out. I can't enlarge it without it crashing again at the minute. But this point here where my cursor is the area of concern that we're treating. So any pain, generally speaking, it affects the medial calcaneal tubercle, but pain can radiate all the way through into the middle of the arch too. So that's why plantar fasciitis is a real common condition affecting a I think I read some research says it can affect up to 90% of the population at some point. So it's really important to get your prescription right for that. So thanks for taking us through that there, Jamison. Have you got any questions or any comments in there, Victor, from your end of
No.
You know,
you're clearly the experts here. I'm actually learning today. I am learning. That's my mission, to listen and to learn.
I think that's a good thing about these sessions. I think we all learn a bit of something every time we do them.
Some more than others, though.
So we've done Morton's Neuroma, we've done plantar fasciitis heel spur. We're going to move on to Hallux Limitus, because this is another big one. We see loads of this Hallux Limitus. So if I just show you Hallux Limitus, essentially this is affecting the big toe. The big toe is the most common area. So if we're looking at underside the foot, this area here, your big toe. So these are the bits of the toes that you can see that stick out and you wiggle around. Then you've got the ball of the foot, and essentially it's the first metatarsal phalangeal joint. So that's where you tend to get arthritis, really. As with any joint, you can get a debilitating arthritic condition here, and that can give you a lot of pain, immobility, and loss of gait and function. So this is what we want to try and treat with our prescription. Again, if we don't get this treatment right, it can end up requiring invasive treatments, as with any other complex foot and ankle condition. So you can end up needing pain relieving injections, and a lot of cases this can end up in surgery. So we want to control the joint pain, range of movement, and discomfort whilst this goes through an almost fusion process, and that can take anything from months to years, and it's careful management of that patient through use of proper footwear, and of course orthotics have their real big role in trying to prevent further destruction of the joint and to help reduce pain and symptoms and keep you walking comfortably. So again, this is going to a 3D print shell, which obviously is a feature of the programs tonight. But obviously it speaks for itself, because you get such a lightweight, flexible material, and at the same time, this can help with the right prescription in place, can help to reduce the pressures on the first MTP joint or the big toe joint, as we see. So here you can see we've got the tri-posts built underneath. We've got a real thin shell, 2-3 millimeter. This nice orangey top cover, which is a perforated EVA, correct me if I'm wrong, and then built within that, I'm not sure if this one does, but you can see there's a stiffer plate to the forefoot, and also a Morton's, what do we call it, a Morton's
extension.
Morton's extension, which I'm not sure the camera's going to pick that up, but you can see it's almost like a splint built in to help reduce bending of the big toe. You can reduce it bending while you're walking, because of course normal function is for you to land at the heel, you roll slightly onto the outside of your foot, then back into the inside, and you're supposed to toe off and push off with your big toe. And of course, if you've got arthritis in there and painful swelling and inflammation, that's the bit that you need the control with. So with appropriate footwear and a prescription orthotic to help to balance your foot and reduce the pressure on the great toe, you can carry on leading a full independent life and hope to avoid any further interventions. So there's a real good standard prescription that you can see there, and of course that just requires modification to suit your individual clients. And again, this is just to think that this is an international program we're doing here, guys, with Europe and the States, and these are pretty tried and tested methods. So it's really important for those guys out there in sports injury clinics, podiatry clinics, physiotherapy clinics, chiropractic clinics, to have orthotics as part of the toolkit that you require to help treat these conditions. It's a no-brainer. So do you want to talk us through how you go about filling in a prescription for this, please, Jamison?
Sure. So again, as we showed before, you can change the top and bottom covers and shell thickness and things like that based on your preferences as a clinician or the patient's preferences. But for this specific pair that Abid is showing you for Hallux Limitus, most clinicians are going to do a Morton's extension. It can be in the shell in 3D print or polypropylene if you use that. The nice thing with the 3D print is that you can have a 3 or 4 millimeter shell, and you can still change the Morton's extension into a different thickness because it's not a continuous piece like a piece of polypropylene. So you can keep it a little bit thinner to be more accommodative for the size of the patient's foot and the allowance of the shoes that they're wearing. So you could also do it not in shell, and you can do a piece of EVA, which isn't going to cross the joint and the distal edge of the shell in the same way. So it's going to be separate pieces. It's not going to be continuous, but it will still block the movement with millimeters more or less equating to degrees. Another thing that I usually recommend going along with that, that's in the pair Abid showed you as well, is a Met bar. So the Met bar is going to actually shift the forces when the patient's standing. So there's a little bit more force in the anterior and anterior medial arch sitting right behind the first MTP and the hallux. So there's not quite as much force just while in static standing through the painful area. And it's also going to create a little bit of an anchor so that you can have a rocker bottom or somewhat of a seesaw so that you get a little bit more momentum and movement earlier on in the anatomy of the foot instead of all of the dorsiflexion being through the hallux at toe off. There's a lot of other options for hallux pathology. You can have a dancer's pad. You can have a reverse Morton's extension. You can have a kinetic wedge. And then you can have first ray or first MPJ cutouts. And really different patients will respond to these in different ways, and different clinicians will use them for different reasons, whether the objective is more to block the IPJ movement, or if it's more that you want to allow more metatarsal movement earlier in the foot while still supporting them with a biomechanical medial arch. So there's really a variety of ways that it can be used and a variety of reasons the clinician might use them.
Okay.
I've got the anatomy working there, I think. Yeah, so you can, great. Okay, so yeah, we can see much more detail with the anatomy now, with the hallux there. We talked about heel pain earlier, and if I add in here hide this, I'm just going to add in the nervous system because we wanted to see those plantar digital nerves. There you go. That'll take a few minutes to load up, and we can show you quickly the Mortons and Neuroma stuff again. Okay, great. Thanks, Jamison. Let me just take that stream off, and then let's move on to the next prescription. So we've done 3 now. We've got 2 left to go. So the next one will be we have posterior tibial tendon dysfunction, and we have the Achilles tendonitis one. So let's talk about posterior tibial tendon dysfunction next.
I have my screen up right now, so pull it down so they can see. There you go. The orthotics a little bigger.
Okay, so posterior tibial tendon dysfunction. So this is, I'm going to flick over to my anatomy app and try and talk you through this. So let's get this ready. Okay, so let's see if I can just swing this around a little bit. So this looks more like the flexor tendon, but posterior tibial tendon dysfunction is the most commonly misdiagnosed and misunderstood condition, I think, affecting the foot and ankle. Essentially, there is a tendon that runs down the medial aspect, so the inner side of your foot and ankle. This can get ruptured, this can get torn, this can get inflamed and swollen. It can become overstretched, and this then can lead to a collapse of the longitudinal medial arch or result in overpronation, which then can go on to affect the knee, hip, and back. So it's these tendons here really that come in and insert and attach. They have 2 attachments. One is under the navicular right here, and the other main branch of the attachment will attach under the sort of the midfoot articulations right here. So in my podiatry clinic, I see this several times a day, and patients don't always come in with pain in this area where the problem occurred. It can be anywhere along the foot of the ankle. It can sometimes lead to lateral ankle impingement symptoms. It can lead to sort of lateral foot problems with peroneal tendons overworking. It can lead onto Morton's Neuroma. It can lead onto plantar fasciitis and any of the conditions that we've spoken about. So the key is really to identify it, and we'll probably talk about the clinical indications in more detail another time, but it just gives you a basic overview that common term that you hear about overpronation. If you're seeing too much of that, you really should investigate it for posterior tibial tendon dysfunction. They can require a scanning or more detailed analysis to help you to make that diagnosis. That could be an ultrasound scan, could be an MRI scan. But again, a lot of patients actually that I see come in with a previous diagnosis of plantar fasciitis. They may even have had a lot of treatment for plantar fasciitis because if the medial arch starts to tilt inwards, it can put a great amount of pressure onto the plantar fascia and cause that to break down and give you symptoms. But actually, if you look carefully at the biomechanics, and we are planning on doing a biomechanics course with Edser too, and we'll talk about that there in more detail. But overpronation really here is the underlying result of a problem with this tendon or this group of tendons here. And if you get that, then it's maximum pain, maximum symptoms, and very poor gait and poor walking pattern. So it's really, really crucial to get this right, because again, like all the other conditions we've spoken about, if we don't get this right at this point in time and catch it, this can progress further. So we can categorize as posterior tibial tendon dysfunction from a stage 1, where the condition is just begun and you're starting to get inflammation and pain, generally speaking, anywhere on the medial side of the foot or the ankle. This can progress all the way to a stage 4. If you're looking to get to a stage 4, that's almost a complete collapse of the architecture of the foot. There's 28 bones and 33 joints, plus all the network of tendons and muscles in there. So for that complete failure and loss of the intrinsic function of the foot is catastrophic, and this is a lifelong problem. I'm sure the guys will agree. We tend to see this a lot in younger guys too. And again, it's just crucial to get the treatment right, because if we don't catch that and try to restore foot architecture, foot function, whatever you want to call it, then these guys are just really going to suffer all the way through life with mobility, pain issues, and also poor function. They'll often end up not being able to participate in sports, and generally just don't want to do much if it involves walking. With the older age groups, of course, if we don't get it right, they can end up requiring surgery. And I've got an orthopedic friend who's a really big fan of flat foot correction, because of course that's the general term we put on this. You will end up developing a flat foot potentially if we don't control this condition properly. And several of my orthopedic friends, as I was saying, are real big fans of correcting flat foot deformities. But of course, it's a lot of work, it's a lot of surgery to go through. It can involve a simple sort of tendon transfer, so they can take out the diseased portion of the tendon and reattach the two ends. But often it can end up with bony bone work, because the heel here will go into a valgus position, so it'll be tilted inwards, and there'll be a deformity the subtalar joint and the talarnavicular joint. So some of them like to do osteotomies. They cut chunks out of the heel, realign them, pin them, screw them. Either way, it's a surgery you don't really want to have if you can avoid it. Well, obviously, like most. But the key really is that how useful and beneficial orthotics are if it's just caught at the right stage and you've got your prescription right. Because the number of times I've seen podiatrists and other healthcare professionals out there design an orthotic for this condition, but sometimes just miss the basics, and therefore don't control the hind foot and midfoot deformity that's developing. And also, if you've got too much arch in there, I find it can just be really uncomfortable for the patient. So the key to this condition is getting the orthotic prescription right. If you do, you've probably saved that patient from lifelong suffering and disability. And if you don't, that person's likely heading towards some kind of surgical intervention. There's not a lot in between. There's no tablet for this. There's no specific injection that can help to cure it. You can settle down the symptoms, but you either need a serious orthotic to stabilize and improve that, or you're going to need an operation. So really, really important to get this right. So let me just get that out of the way so we can talk about this in more detail. We've lost Victor there. I'm just going to add him back in. There's Victor again. Okay.
Thank you.
So loss of the medial longitudinal arch. So first thing is, you've got to try and restore that without making it uncomfortable for the patient to wear them, because too much pressure in the arch is about the point where you get the swelling and inflammation on the tendon. So you can't be too aggressive in there, but at the same time you need to stop the heel going into a valgus situation as well. So let's talk about this prescription. So this again is a 3D print, but this is slightly more rigid. We also have the posting for the rear foot control, so we can get that subtalar joint axis or get that valgus heel into a straight position. You'll notice that there's also a bit of an extra bit here. So this is an extension, medial arch extension. Sorry guys, what do you call that? The technical term for it is
an MLA.
And that's milled into the actual shell.
MLA expansion.
So flange, flange I would say is soft, but this is quite hard. This is part of the actual shell.
A flange will be with Morton. This is an MLA expansion.
This is that's an expansion. Sorry, yeah, that's exactly what I'm looking for. So it looks simple and straightforward, and we generally have a deeper heel cup, I think, to control that. So you can see how much my fingers going deep down into the contour here, because you need to stabilize the rear foot and the midfoot. And try to reduce the pain on the medial arch. So do you want to talk us through that prescription, please, Jamison?
Sure.
Thanks.
Let me know when I'm live.
Okay, you want me to put your screen back up? So
sure.
You're up.
So as Abid mentioned, it's a really important symptom or diagnosis for patients that they're going to need that they get custom orthotics. At the same time, it can be quite tricky, and many clinicians do struggle with prescribing the correct orthotic. As he alluded to with the anatomy, this is one of those situations where we see that it's complicated because the patient is having some inflammation and point tenderness in the exact area that we need to apply correction to put the foot in a proper alignment in order to alleviate the symptoms. So you kind of have to play with it a little bit. The majority of the time, ignoring some of the other things from earlier, the majority of the time, these patients, I see that it's better off if we go with more like a moderate contact, so that we lower the medial arch 3 millimeters. That's going to take some pressure off of the soft tissue as well as the navicular in the medial arch where the posterior tibial tendon is running. So what we have to do then to make up for that is either change from no posting and give them 3 millimeters of intrinsic or extrinsic posting here, or as we like to do with 3D print, you can go down to the bottom and add your 3 millimeters of tripod varus posting. So if you can picture the anatomy and the orthotic and your patients, what's happening is you're actually allowing the arch to collapse a little bit from the position that it might be in optimal subtalar neutral, for example, but then you're going to rotate at the calcaneus to gain that 3 millimeters or 3 degrees back. So you're just kind of playing with it a little bit. The other options that you have, as Abid showed, you can do a medial arch expansion. That's going to be more in a rigid, flatter type of foot that has this condition. If they do have a flexible foot, you could also use a medial flange, either soft or rigid, if you think you're going to be able to correct them and get them towards a neutral position. Again, for padding the area and also filling that arch that you drop down to moderate contact. You can put an arch pad in either very soft or pour-on material, and that's going to help bring them back up but not make it a solid shell material that's underneath them. Of course, you can add a Met bar again, and that's going to limit the forefoot pronation. So there's really options that you have. It's just a lot of patient-specific symptomatic decision making based on where exactly is the tenderness, whether or not they have a navicular deformity, a drop navicular, or if their navicular is movable or rigid. And another thing that you can do is you can add some height in the heel so that you put a little bit more slack on the posterior tibial tendon and the posterior tibialis, either with a heel lift extrinsically, which you can actually add into the tripod posting, or instead of that, you can do it in soft material with heel cushioning, but instead of just using Poron, something more like very soft or soft material. And that's going to put them into slight plantar flexion, similar to what's coming up next, which is Achilles tendonitis, and that will help them as well. So really, you obviously you don't want to have to make it over and over again, but with experience, with the different presentations from different patients, you'll learn which might work better in which situation instead of just relying on full arch contact.
Yeah, I think I generally go for a lot of valgus control and reduction in the medial arch, as you're saying, and as deep a heel cup as I can get into a shoe.
Yeah.
For that rear foot control. So yeah, that's a pretty well put together. Anything you want to comment on that there, Victor? I mean, any problems you see commonly coming into the lab with prescriptions for such conditions? I mean, do you get many people asking you for tips and advice, or do you have to find that you're changing prescriptions and altering them much? Or
to be honest, like when they have questions about complicated cases like this, I tend to refer them to Kirk, Jamison, or Sergio. Validating orders for me is the 80-90%, which are the straightforward ones. Today is a day of learning for me. Okay, I can say I think
I'm sure you do get some issues with clients occasionally that are telling you
I do, and
their medial arch, and now you're seeing why.
I do, and I know to resolve them, but more for experience than because my clinical background is because the only thing I do the whole day, and eventually people learn, you know.
Yeah.
So I think, as I said before, I think acknowledging someone's limitations is not a weakness but a strength, because it helps you concentrate in your skills, your abilities, while delegating in people that are more capable than you and they have a clinical background, which is what I do. I think it will be dangerous for me to assume I can do the same from you and Abid. Yeah. That will be insane, actually. You know what I mean? It's like one of these central defenders that they think they are much better at what they think they are, and then they do mistakes and you lose 3-0 because they did mistakes in the defense. It's a bit the same, you know. You just today for me, it's a very good example. I really like the software of Abid, and hopefully the people who are going to see these videos learning as much as I am learning today.
Yeah, I think you undersell yourself there, Victor. To be honest, from my experience working with you over the years, you are the first point of contact, and if you pick up any problems with the prescriptions, you're the first one on the phone or the email. Yeah. And actually, you don't just contact people; you just harass them until you get the answer.
Yes.
Because I think you've got a good sense, you know, of what's right, what's wrong. You've seen hundreds of thousands of prescriptions over the years, probably. So, you know, I want the audience to appreciate your input to the market and the whole profession.
I am persistent, and it's true. I am the opposite of the mañana mentality. I like everything done during today. Today is already too late. I want it for yesterday.
Yeah. If it wasn't for the accent, I'd swear you're English. Okay, I'm going to kick back onto the software because I've actually got this working real nicely now. Don't jinx it. Okay, we're going to look at Achilles tendon next. So let me just flick onto my software here so I can manipulate it, the image. So here we go, guys. Check that out. That's what should have been working at the beginning of the program. Sorry it took so long. It was just been an absolute fiddle. But here's a bit more detail as well. I've added some muscle layers, and I've also added those tendons in. The posterior tibial tendon you can see here now clearly. Earlier I think we were looking at the flexor tendon, so apologies on that one. But now we're going to focus on the Achilles tendon. So for those that don't know, the Achilles tendon, it can be found right at the back of the heel, back of the foot, back of the heel. So if we're looking from the inside of your foot, you're going to see this white structure here that comes from higher up. If I can just swizzle this around. So it starts right up at the top of the leg, about a third of the way up the leg. So you can see what I'm trying to show you is this white line, which represents pretty much your Achilles tendon, maybe a little bit of plantaris coming down here, but we'll talk about that in another program. And you can see here, I think we lost Jamison somehow. Let me just add him back in. Uno momento. Oh no, he's back. Okay. So and you can see it originates from the gastrocnemius, so the calf muscles at the back of the leg, right at the top of the leg, just below the knee. You have your two heads of gastrocnemius, and that then turns into the tendo-Achilles junction here, where the fibers of the Achilles tendon originate from the gastrocnemius muscle. They run down the back of your leg. There's not a lot of other muscle here at the back of the leg. It's pretty much all tendon. If you lift your foot and your toes upwards and have a little feel around the back of the heel, you'll be able to feel this Achilles tendon sticking out. And this effectively makes the foot move up and down. It's a really important structure. It's there to stabilize and to give dorsiflexion, plantar flexion capability to the foot structure. And it's a weak, technically a weak part of the body because there's no vascularity to this area. There's no blood supply to it. So if this Achilles tendon gets injured, and of course you can, like any other structure, you can get rips, tears, or you can get tendinopathic changes. Generally speaking, most conditions affect the sort of mid-third of the Achilles tendon, so around about here. So if you find the base of your heel bone and about 2 to 3 centimeters up from there, that's where I think 90% of cases happen at this, what we call the mid portion of the Achilles tendon. And that's where you can get degenerative changes. You can get tendinopathic inflammatory changes, as I said earlier, rips and tears. So it's a real common area for problems, not only in the sporting athlete, but in the middle-aged population, the elderly population, anybody and everyone, all ages, all ranges, including children. In children, we call it a Sever's disease. But we'll probably have to talk about that in another program as well. So essentially, that's your Achilles tendon. So what is the purpose of treating Achilles tendonitis, and why do we need orthotics? Well, again, if we're looking at the biomechanics of the foot, if we pick up a problem there, you may be more supinated, you may be more pronated, you may have a functional Hallux Limitus or another condition that affects the way your foot works, because if your foot isn't able to move up and down properly, you can't keep this tendon healthy. And also, as I said, it's prone to injury, so twists, turns, sprains, strains can all develop, cause problems with Achilles tendons. Generally see them a lot in the, I see them a lot in the older, probably over 50s age group, where you can get calcifications, you can get osteophytes and all the other things we mentioned earlier. So it's a really, really common area. Orthotics, if all other physical therapies are not working or as part and parcel of the overall treatment and rehab protocol, orthotics can be ever so useful. I have a lot of physiotherapists, physical therapists, referring patients to me for orthotics after they failed conservative management, because again, like all the other conditions we talked about this evening, if we don't get this right and we can't get on top of it, you can end up requiring more invasive treatments, injections, etc., and ultimately surgery. And again, I've got several orthopedic friends that just love to get in and treat Achilles tendon problems. They can be tricky to treat surgically, but it's the recovery, generally speaking, afterwards. The recovery for Achilles tendon surgery can be really long. So sometimes the recovery is longer than the length of the condition itself. Typically, a lot of these will burn themselves out in 18 months to 2 years if you can manage them properly. But those that don't will end up requiring some kind of surgical intervention. And there's just a whole bunch of things to talk about in that regard. Let's keep it orthotics for us for now. So I'm going to just switch this off, get that out of the way, and let's show you our Achilles tendon prescription. So again, 3D print, and I just love this stuff because of the accuracy of the actual, you know, when we say 3D print, it's coming off your 3D scan. And again, just to highlight, there are many other methods of making your orthotic prescription or taking scans of your patient's foot. One of my bugbears is pressure plate scans, you know, and trying to make a 2-dimensional pressure plate scan into a 3D model of a foot where you can get a really accurate made orthosis. I've played around with these gadgets for a long time, and they're quite popular out there at the moment as well, aren't they, Victor? But you know, inherent weaknesses of actually being able to capture the foot, because ultimately, if you can't get the shape and the fit right to the foot and the correction in there and be able to get it into the footwear, then you know it's a very static problem. So we've got our nice 3D printed shell, whatever rigidity you feel you need. The top cover in this case is a perforated grey EVA, so you can see the perforations which help the breathability. We have the nice contoured arch area, again some depth to the heel cup here, and we also have a built-in heel raise, because the point of the heel raise is to plantar flex the foot slightly so that we're taking pressure off the rear of the heel and the Achilles tendon, and that's one of the principal ways. So not only are you correcting the underlying biomechanics, so you've got to look and do your assessment very carefully, but you're also giving them a heel lift here, and you can see how this one's tapered in, so you can't see that actually that would take up much depth. It's nicely rounded, and it's not just a big post that sticks on the bottom, which I've seen a lot of, which can be really difficult to accommodate in footwear for one thing. Plus they can be uncomfortable, and of course you generally want to do this bilaterally, because you don't want to just heel raise one side if you can help it. You want to kind of keep them even, otherwise you can end up giving them a functional leg length difference and a whole host of other problems. So also I note there that we've got a metatarsal bar built in, which I think is turned into a common feature also. So if you'd like to take over from there, Jamison, and talk us through prescription writing for your Achilles tendon device, please.
Sure. This one's
your streaming.
This one is super simple, but
it's only super simple, I suppose, because you guys have done all the hard work and you've put all this, you know, sort of pre-prescription in templates in there.
But so obviously you can manipulate the heel height. Those are used in other times of course, for leg length discrepancy on one side or the other instead of both. But typically, Abid, correct me if I'm wrong, I do see some higher, but I think 3 is a fairly perfect number. 2 might do the trick sometimes. Once you start going 4 or 5 and above, you're kind of adding some bulk into the heel that's not really necessary. I think 3 is a good number for the heel lift for Achilles tendonitis. And then with that, you can do your no posting and flat heel like you did before, and then you'll get a posting looking like the one that Abid is showing, that's a rounded posting. You can also do your standard heel posting, which is going to be still a bit rounded, but more squared off. And the heel lift will be added to the bottom of that material. The concern for that is it does get a little bit heavy and hard when using that method. So I try to steer clients away from it as much as possible. And then, of course, your final option is going back. Well, not your final option. Your third option is going back and using your tri-post, which those can be extended so there's a lift built into them. And then lastly, you can have no posting. And again, go back to your heel cushioning, and you can put in soft, semi-soft, and whatever level of cushioning there, knowing that that is going to come down just a little bit. But as Abid was saying, this is a chronic pathology. It's not typically an acute injury. So it's something where if we are able to heal it, the orthotics are probably going to outlast the symptoms for the patient. So if the EVA does get stamped down, let's call it, over time, then they're going to end up more in the position that they need to be in a biomechanical device, instead of continuing to have the heel lift and continuing to be in site plantar flexion. Not that that would necessarily hurt them, but it just might not be as necessary anymore. The only other things I would add for Achilles tendonitis outside of the heel lift is, depending on, again, the location of the discomfort, be it patient report or palpation. If it's more medial or lateral, one side or the other, it might be because the foot is overpronated, supinated, or varus valgus, causing the force accumulation on one side of the tendon versus the other. And then you might want to use a little bit of a wedge in the hind foot just to kind of kick them at heel strike into a neutral position so that the gastroc and Achilles tendon can control heel strike and as they're walking into mid stance in a proper neutral position instead of being out of alignment, and that'll help as well.
Brilliant. Okay, that's nice and straightforward. So really concise. Thanks, Jamison.
Mm-hmm.
That's the five basic prescriptions covered for you. We have another 5 to do, but we're going to do that probably next week or the week after.
Better the week after, because it will have Jamison is going to be around, so give us time to organize. We have trips.
Yeah, Monday I'll be in Dubai.
Monday you'll be exactly. It's gonna be difficult.
Yeah.
So next up, we've got whenever we get around to do it, we got hammer toes, we got EVA PTTD here, we've got midfoot arthritis, big one, and peroneal tendonitis. 1, 2, 3, 4. We're missing one there. Oh, okay. And then also we have ankle arthritis. Ankle arthritis we've done there too. So hopefully that worked well. Then I'll just stop recording. So thanks to the audience for watching. And if you have any questions, get in touch with Victor and the guys at Edser. They can help direct your query. Have a good evening, and it's thanks from all of us.
Thank you. Good night.